To talk about secondary iron overload or secondary hemochromatosis. We talked about hereditary hemochromatosis, hemosiderosis, but now we will talk about a secondary iron overload, namely someone who usually gets transfusion or something else because iron to get into his body. So, excess iron, repeated blood transfusion, oral intake, uh, and we will see what are the causes that the patient needs a blood transfusion. But like iron overload in other diseases, there are consequences. Liver disease, which is the most common organ which is damaged, cardiomyopathy in the heart, diabetes, which is the result of the pancreatic iron deposits, which cause insulin deficiency or damage to the pancreas and insulin deficiency and diabetes, erectile dysfunction, which can be throughout hypogonadotrophic hypogonadism from pituitary iron deposits, which eliminate in the end testosterone and arthropathies from joint iron deposition. Now, in the diagnosis, we will see that serum ferritin will be high, iron will be high, and transferrin saturation is one of the important things because it's a very, very good tool to understand if the patient really has iron overload. If the saturation is below 45 is percent, it has high negative predictive value for iron overload. Now, the treatment is by iron chelation, and the main treatment is iron chelation and not phlebotomy because those patients usually have a reason for the need from transfusions. The reason is usually low hemoglobin. So, if we will treat them with phlebotomy, we will get their anemia even worse. So, the main treatment is chelation in contrast to hereditary hemochromatosis. There we can use phlebotomies, which is maybe the main treatment here in secondary iron overload. No. So, what would cause us to use these transfusions? So, typically, hemoglobinopathies, problem with a hem synthesis and or abnormal hem, sickle cell, which is hemoglobin S, thalassemia, which is a problem in creation of hemoglobin in the chains of hemoglobin, sideroblastic anemia, a problem with utilization of iron with sideroblastic macrophages that can be seen in the peripheral blood smear. Congenital hemolytic anemias, hemoglobinopathies, which can cause hemolytic anemia because they don't pass really well in the spleen and they get sequestrated in the spleen and destroyed, hereditary spherocytosis, which also cause the same thing, and myelodysplasias, which can cause cytopenias. Okay, so increased iron absorption, exogenous iron given to treatment anemia, and repeated blood transfusion, those are the main causes of iron overload. Remember, each blood product of 500 milliliter of blood contains 250 milligram of iron, and usually the tissue deposit of iron becomes significant after around 40 units of blood transfused. This is because it's get to more than around because this is in the amount of around more than 10 grams of iron. And in hemochromatosis, it's also uh, above 10 grams of iron. Okay, now when we have ineffective erythropoiesis, there are some, uh, let's say, hormones that are released, like erythroferron, that what they do is suppressing hepcidin. Now, hepcidin is important for inhibition of iron absorption. Now, when erythroferron is secreted in large amounts, hepcidin is low, so iron is absorbed. And if there is ineffective erythropoiesis, we will absorb a lot of iron to try to compensate for this. But we will absorb too much. The problem is that we can't uh, create erythrocyte for some reasons, and you can see the reasons here. Okay, uh, the symptom and sign of iron overload is like we said in hemochromatosis. In the liver, they can cause cirrhosis and hepatocellular carcinoma. Liver is the most common organ to be damaged, and the complications are most commonly there, but not just there. The heart is the second organ to be damaged with cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy. The pancreas also, and we talked about it, it caused the diabetes insipidus. Hypothyroidism can also be caused, erectile dysfunction, hypogonadism. Gonadal iron deposit is the reason for erectile dysfunction. This is the reason. Okay, so how we diagnose it? We check for iron levels. We check for transferrin saturation. Transferrin is the uh, protein that is has the, let's say, the role of transferring the iron in the body from place to place, from tissue to tissue. If there is a problem in transferring, the iron gets stuck in the liver. Now, transferrin saturation and iron overload is usually above 45, is usually above 50. So below 45% of transferrin saturation has a high negative predictive value for iron overload. If the patient has low transferrin saturation, we think that probably the patient doesn't have iron overload. Okay, also other thing that we can see is elevated levels of iron in the blood, elevated ferritin levels. Okay, serum iron usually above 300. Okay, now treatment. Now treatment is usually chelation and not phlebotomy. We can use phlebotomy sometimes, but we need to be very careful because if the patient has anemia, we can make the anemia even worse. And those patients with hemoglobinopathies, with hemolytic anemias, with sickle cell anemias, etc., can have anemia. So phlebotomy might be a problem. Therefore, we are using chelation, iron chelation drugs, like you can see here, those three drugs. Now, the ferroxamine is an iron chelation drug, which is a little bit problematic because it is very hard to use. You need to give it subcutaneously for 8 to 20 to 12 hours a day overnight, injected into the subcutaneous slowly 5 to 7 nights a week. It's very complicated, so it's not it's a problem. Also, except for the complication, there are adverse effects: hypotension, GI disturbance, anaphylaxis, vision and hearing loss. It's quite complicated, and therefore the 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 use uh, the adherence of the patient for the treatment is can be low. The Ferrasirox is much more convenient. It's a drug oral chelating agent, effective. It can be used once daily, 30 milligram per kilo once a day. The ferripron can be added to the Ferrasirox, again oral chelator, to reduce more the serum ferritin. We can stop or consider stopping it when the ferritin is lower than 500. Here it is also. You can interrupt the treatment and observe, and when ferritin goes up again, you can return to the treatment. Okay, adverse effect also, there are GI and rash. Liver kidney function should be tested and observed. So the idea of iron chelation is to remove or to reduce the risk for complication that we said. If there is cirrhosis, you should screen for hepatocellular carcinoma with liver ultrasound every 6 months. Okay, now about the diet: reduce alcohol, reduce vitamin C, reduce too much from these products because they can uh, elevate the iron absorption. About iron in the food, like for meat and liver, not necessary to restrict if there is a, if you can. Okay, so this was about iron overload. Let's talk about okay. So let's sum it up. So a accumulation of iron in the body, this is secondary iron overload from something that we insert in the body. What are the causes? Iron transfusion, blood transfusion, iron loading anemias, and chronic liver disease. Chronic liver disease. This is not a very good presentation of the liver. Liver. What? I don't know what they wrote there. Leave that. Okay, so symptoms can be fatigue. This can be the first symptoms that can be very mild, and you can not even notice this. Joint pain because of the iron in the joints, abdominal pain, and heart problems. Not sure in this. Leave this. We are usually not using phlebotomy. We're using iron chelation treatment, and of course treating the underlying condition. Okay, but phlebotomy, remember, that's usually not used because they have anemia, and that we don't want to do this. Okay, never mind this presentation. So this was about secondary iron overload. Thank you very much. If there are any corrections, please correct me. That's it.